see here. Make sure you're muted, everybody, unless you want to speak. Okay. So this week we and we will be talking about this again, but postpartum is a very critical period, and we're worried mostly about bleeding, excessive bleeding. The number one cause of mortality, maternal and fetal mortality, is postpartum bleeding. Well, actually, it's just maternal mortality. And so, as nurses, if we work in postpartum, we are certainly attuned to what we need to do to prevent a death of a mother due to any kind of complication in the postpartum period. And we'll be talking about complications not this next week, but the week after, when everything should be making sense to you. Now, I know you took a very difficult exam, okay, and I know you might feel frustrated and maybe even discouraged, but don't feel that way right now. I know it's easier said than done, but the first exam is a difficult one. Number one, this is all new to you, okay? Pregnancy is probably all new to you, and it's your first exam, and it is a specialty course, so it's a little more difficult. And there are several mistakes on the exam, or several questions that we had to adjust for. So you're getting an extra 6 to 8 points because of that. And as soon as we're done our time discussing our case today, I will be available on chat for you, or you can text me and I will tell you your grade. We've made adjustments already, and the adjustments are showing on ExamSoft now. So I can let you know what your grade is as soon as we're done class, okay? And if you scored less than an 82, 84, you do need to meet with me, okay? And I sent you an email about meeting with me Monday or Wednesday, or if either one of those times don't work for you, then just send me a text. Fastest way to get a hold of me. And I'll get you set up to meet with me so we can go over maybe, and even though I might go over some of that in class, meeting one-on-one helps me to look at your exam, talk to you, and see, is it that you just didn't know? Or maybe the way you took your exam, or how you answered a question. And it's very valuable time. So even if you got 100%, then you need to meet with me briefly, okay? Just so that we can talk, and so I can get a feel how you are doing. I value that time very much, and it gives me that one-on-one time with you to see maybe the obstacles occurring in your life that might be preventing you from doing better, okay? Because the whole goal here is to get you through OB. Okay, so during the postpartum period, as a nurse, as a registered nurse, you have a lot of responsibility. We need to prevent excessive bleeding. We do that by maintaining uterine tone. We don't want a flaccid uterus, ever. Okay, as long as they're in the hospital, we need that uterus to be contracting and stopping the bleeding. We need to prevent bladder distension. If a client has had an epidural or a spinal, they don't know that their bladder is full. So we have to give instructions to our clients to empty their bladder every couple hours. We need to prevent infection. And this also is about teaching our clients about hygiene, okay? Promote comfort. There are nursing strategies to help clients feel more comfortable during the postpartum, especially if they had some surgery, okay? Non-pharmacological things we could do, as well as pharmacological. And then we have a new baby, okay? A new person in mother's life and in the parent's life, or the people involved in this family. And so we want to promote the bonding. There are some things that evidence that we can see, some cues that mother is bonding well with her newborn. And what are those things? Okay. So let's get rid of this slide. Okay, here we go. So, stage 4 is postpartum. Okay, it's a time of uterine hemostasis. In other words, the uterus has exposed blood vessels, and we need the uterus to contract to constrict blood vessels where the placenta was attached. Okay, it takes a while. Okay, oxytocin is our friend. It's a hormone. Okay, remember we were using oxytocin during labor to cause uterine contractions to promote cervical dilation and effacement. We use oxytocin in the postpartum period to continue those contractions so that the uterus stops bleeding. And oxytocin is produced by the posterior pituitary during breastfeeding. Okay, so we still need this hormone. Okay, we can provide it exogenously through the IV or an intramuscular. So hemostasis, the term hemostasis, it means that there in the body, there's a balance, okay, between the blood bleeding and the clotting. We want it to be balanced, okay, so we don't lose too much blood and so we don't have too many clots. And it's called hemostasis. So uterine involution. So when the uterus contracts postpartum, it's not only stopping blood flow, but it's reducing in size, and it's called involution. Okay. At postpartum, we want to see that belly button, the fundus at the belly button, or just 1 centimeter above it. Okay. So the fundus will then descend 1 to 2 centimeters every 24 hours. And usually by 14 days, we are no longer to palpate that uterus. So with the expulsion of the placenta in stage 3, the estrogen and progesterone levels, which throughout pregnancy, remember, continue to climb to support the growing fetus. Okay, but once that placenta is delivered, remember the placenta was the source of the estrogen and progesterone. So once we get rid of that placenta, then the estrogen levels and the progesterone levels drop. Okay. And there are outcomes with that, and we'll talk about those. But oxytocin from the posterior pituitary continues to be released so that when a mother breastfeeds, she has uterine contractions. Okay, because that's what oxytocin does. It lets down the milk or the colostrum. Okay, and the pains that she feels after delivery are called after pains. Okay, they are uterine contractions and they still hurt. Okay, prolactin levels is another hormone. It begins to climb. Okay, so prolactin and estrogen have an indirect relationship. Okay, the higher the estrogen, the lower the prolactin. That estrogen has dropped off. Now we need prolactin levels to go up because prolactin is a hormone that causes production of colostrum and milk in the breast. Okay. So this is a PowerPoint, that slide that I gave you, and it goes over all the things in how you assess a client during the postpartum period. Okay, so study that PowerPoint. It has most of the information you need to know about a normal postpartum period. And then so let's quickly do a case study since we don't have that much time. Okay, so postpartum period, let's see. I gotta get rid of this one. So you see the postpartum, right? Case study? Do you see the postpartum case study? No?
The screen is just black.
Okay, let me try it again. There we go. Thank you very much. Okay, postpartum. So who do we have? Do you remember we talked about a 40-year-old woman named Abby? She was had trouble getting pregnant her whole life. And finally she was able to conceive, but she had in vitro fertilization. She's admitted, and usually women who have fertility assistance deliver early. Okay, but she was able to carry hers until she was 42 weeks. So she's really post term pregnancy. And there's some risk associated with that. The placenta is getting old. Okay, it's not meant to live forever. Okay, so it might not be as efficient. So we might see amniotic fluid drop off, and we might see babies get too big. And so women have trouble during labor, and it's called labor dystocia. The word dystocia just means difficulty. Okay, so we used an epidural anesthetic on her during active labor, okay, to give her some comfort. And she had a 20-hour labor. It was very long, okay, and she sustained a laceration at the posterior portion of her vagina. Okay, and she actually lost more blood than what we normally see in a vaginal delivery. So 700 mLs is too much. So does anybody know how much on average is lost during a vaginal delivery?
500.
500. So 500 is okay, but 700 is getting up there. Okay, so what are some concerns you have for this client? She lost a lot of blood. Her baby is fine. What are some concerns you have when you think about the whole scenario?
Hemorrhaging.
Hemorrhaging. Hemorrhaging because she has a big baby, hemorrhaging because she has a laceration, hemorrhaging because she had a difficult labor. Okay. So you're going in as a postpartum nurse to assess her, and it's about 6 p.m. at night. Okay. Your client is lying in bed on her back. It's been 30 minutes since she delivered. Okay. What are some cues that you notice when you walk in the room? What are you noticing? Okay. She's diaphoretic. She awakens with tactile stimulation. She says her pain is 4 out of 10. Her fundus is midline, 2 centimeters above the umbilicus. It's soft. She's not having any fundal contractions. You find blood on the bed sheet, and she says she's not voided for 4 hours. Her newborn is quiet, lying in a supine position in the bassinet, which is all normal. Okay. So in this statement, in this description, this client scenario, what are some things that concerns you?
The fundus is soft.
Okay, the fundus is soft, so it should be contracting and firm, right?
She's diaphoretic.
Okay, diaphoresis. Okay, what else?
Blood on the bed sheet.
Okay,
And she
what
hasn't voided. She hasn't voided for 4 hours.
yeah, that's a problem. Okay, anything else?
No, you want the fundus to be midline? Not
The fundus is
umbilicus?
midline.
Oh,
Yeah,
okay.
and we really do want it closer to the umbilicus. 2 centimeters is a little high, and it's because it's not contracting. Okay, so being 2 centimeters above is a concern. Okay,
I would
So
say her
really-
pain too.
for pain, okay. Would you want to do something about that?
I would want to assess it where she's hurting.
Okay, good, very good. Okay. Okay, so you got most of them. Diaphoresis, however, is normal postpartum. And let me explain. So remember during pregnancy, that huge uterus with all that blood in it, okay, that supports the placenta. Once that placenta is discharged or expulsed, that blood in that uterus is then shifted back into maternal systemic circulation. So she's got a lot of volume to get rid of. Okay. So she's going to be sweating, perspiring, and she's going to be urinating a lot. So diaphoresis and diuresis are what we really do want to see during the postpartum period. Okay. So diaphoresis is good. They should be sweating. I remember doing that after having my kids, and it was miserable. But why am I sweating? Okay. We can do something about the pain, but we need to know where that pain is. Okay. So with the fundus being soft, what do you think what should we do?
Massage it.
Oh, yeah.
Okay.
Love it.
Okay. So we do need to massage that fundus. Oh my goodness. I left the numbers on here. Just a minute. I don't want to give you the answers. Hang on just a minute. So I'm going to give you a list of nursing interventions, and you have to put them in order for me. What's the first thing you want to do? Okay, now let me go back here. As soon as I find my screen, go. Okay. All right, so here it is. What do you want to do for your client? What's the first thing you think is really important to do for your client?
Massage the fundus.
So you want to massage the fundus. Okay, we'll say that's first.
Have the client void.
Yeah, really, that would almost be number one. Okay, because it's not going to do any good, and I don't have a picture of it here, but if her bladder is distended full of urine, it's pressing against that uterus. And we can massage, but it's not going to do a whole lot of good until we get that bladder empty. Okay, so let's have her sit on a bedpan. Okay. If she can't void, then we need to get a catheter in her. Okay. And then we can massage the fundus. What else do you want to do?
Call for help.
Yeah, get your team in there. Get your coworkers in there to help you, because there's a lot of things we need to do for her. Okay. What else?
Take flavor.
So she's had a bulky uterus and she has blood all over the bed. What do you want to do?
Needs fluids.
Fluids. Good. Fluids. What else?
Change the sheets.
Huh?
Administer
Change the sheets.
administer the medication, the uterotonic.
Okay. We need to give her some oxygen before that though, right? So what we're trying to do, yeah. Yeah, we need to get IVs and oxygen going, and then we can do the uterotonic. And that's why it's important to bring your coworkers in the room. So you can have someone go grab the medications while you get oxygen on your client. Okay. Changing the sheets would be the very last thing we would do. Okay. Rolling to the lateral position. Why would this not help?
How are you gonna massage the fundus if she's in lateral
Yeah,
position?
yeah, and it's really not gonna help that much. It might help a little bit because she still has a pretty gravid uterus, but she doesn't, or not a gravid, pretty large uterus, but she doesn't have the weight in there. There's no baby, there's no fluid. So it's really not going to do much, okay? So the first thing we want to do, if we know our client's bleeding and she has a flaccid uterus, is we need her to empty the bladder if her bladder is full. And remember, if a client has an epidural or a spinal, they don't know their bladder is full, okay? So unless she already has a Foley, we need to get that bladder emptied, okay? Then we need to massage the fundus. So you need to, either you need to do it or you designate a team member to do that while you get the IV going faster and get some oxygen on her, and then send someone out to get some medications, okay? Uterotonic medications. Medications that actually cause the uterus to contract. Do you know what those are?
Oxytocin, Hemobate.
Yep. So I have them listed here since I didn't erase it. So magnesium sulfate is not one of those uterotonic medications, okay? But the rest of them are oxytocin, methylorgonavine, also known as Methergin, misoprostol, Hemobate, okay? So when you look at these drugs, these uterotonics that cause the uterus to contract, there's some indications that are really a contraindication. We can't give this drug if a client has high blood pressure. So methylorgonavine will increase blood pressure. Okay, so we can't give it to a client with high blood pressure. Okay, if a client has had a laceration, has any kind of repair work done where sutures were placed, we can't do a rectal suppository of misoprostol because we usually give it rectal suppository. Okay, it is a prostaglandin. So make drug cards for these. And if you look up the drugs in your text, they'll be more helpful for you. Okay, so we usually give prostaglandin, misoprostol per rectum, a high dose. But if she's had any kind of repair work, we don't do that. Okay, and then Hemobate is another potent vasoconstrictor. And we give it intramuscularly, just like oxytocin, Methergin, okay? We can give oxytocin IV as well, okay? We can continue a high dose. But Hemobate is contraindicated if your client has asthma. It can cause a bronchostriction. It's really called bronchospasm. It causes the bronchial tubes to tighten up and she can't breathe. She can't have the gas exchange, bronchospasms. Okay, so that's how we fix a floppy flaccid uterus in a client that needs help with contractions. So hemorrhagic shock. You know that losing a lot of blood postpartum is caused by many things. A boggy uterus or maybe laceration that is broken loose. So she could be bleeding from a tear, even though her uterus is contracting and firm, she could be losing for another reason. If you look at vital signs when you walk in the room, if you see a low blood pressure, it's a late sign of blood loss. Your client has already lost a lot of blood. Okay, so early signs of blood loss are going to be the boggy uterus. So we want to do a expectant management, okay, because we expect women to bleed if they had a laceration, if they had a large baby, if they had a lot of amniotic fluid. So there are certain groups of women who are at greater risk for a postpartum hemorrhage. So we have to do preemptive care. Okay, we're going to be more vigilant about assessing that fundus and watching for bleeding. Okay. So once we know our uterus is contracting nicely and firm, we do need to keep an eye on her vaginal bleeding. Okay. We're going to massage that fundus and get rid of all the extra clots and tissue. Okay. And we really don't want to see her bleeding and filling a peri pad any more often than an hour or two. Okay. If she fills a peri pad within 30 minutes to an hour, she's still bleeding too much. Okay. So lochia rubra is what we're seeing those first few days after delivery, 3 or 4 days. Okay. After the 4th day, she's already at home, it should begin to lighten up. Okay. And that's called lochia serosa. Once that week to 10 days is over, then it should be hardly any blood. Okay. More of a white yellow color. And that continues for a month. So you were successful at 1825. You were able to stop bleeding. Your client's uterus is nice and firm now. And you're going to continue to keep an eye on her. You're going to remind her to empty her bladder. You're going to teach her about hygiene. And you're going to be assessing her bonding with her new baby. And so remember, the fundus should be at the belly button or the umbilicus or below, okay? And it should be decreasing every 24 hours. So the next day at the same time, it should be 1 centimeter or 2 below the belly button, okay? So the breastfeeding, if your client asks you, why is she cramping when she's breastfeeding, what would you say?
It's the oxytocin that her body's producing, which promotes the uterine contractions.
When she breastfeeds in particularly, yeah. Good. So we know that she understands that now. After we check her perineum, we can assess her extremities for any deep vein thrombosis. What kind of teaching would you want to do about DVTs to your client?
Walk.
Okay.
Too.
Let us know if there's any pain in the legs.
Okay.
If
Good.
if one leg feels hotter than the other.
Okay.
or more
Good. So
swollen.
okay. Good. So some signs and symptoms. If she hurts, if a leg hurts, if you notice some edema, some erythema, it can be red on the surface and painful and warm to the touch. If that is occurring, we don't want her to walk. Okay, we need to get her some heparin. All right. So we're teaching her about moving postpartum. If she had a cesarean section and it was an hour past her surgery, and she's just now coming to you postpartum, you're going to do the same kind of assessments. Okay, you do want that uterus to continue to contract. You want to look at the incision. Okay, you do want to keep an eye on that, and you're going to teach her about what would an infection look like on her incision and good hygiene. Okay, we still want to talk to her about DVTs, especially with a C-section. She's more at risk for a DVT. And you will learn, if you haven't noticed already or seen, that with any kind of major surgeries, abdominal, orthopedic, that before they go to surgery, we put the sequential compression devices on those legs during the surgery to keep the blood moving in the legs. And we will continue using that machine postpartum until she's up and moving around. So if she had a spinal, it's going to be several hours before she can actually move. So make sure those devices are still operating. Okay. Make sure it's plugged in and it's operating and it's working. It's a great time to teach your patient about preventing DVTs. And then you're going to help her learn about the bonding. Is she talking to her baby? Does she want to learn how to change a diaper if she doesn't know? Or about any circumcision? What does she want to do? Okay, so you're going to watch her bonding with her baby. That's part of your assessment. And then, do you know what one other thing we need to be alert to during the postpartum period besides what we've talked about?
Postpartum depression.
Postpartum mood disorders. Okay, so if she has no history of depression, she might be showing signs of postpartum blues. Okay, which she's a little down. She might be emotional, tearful. She might lose interest in caring for her baby. Those are signs of blues. But if those continue throughout her whole stay of 3 days, we need to make sure she understands that if it continues on for 10 days or more, then she needs to let us know or let her provider know, call the provider's office, talk to the nurse, so that we can maybe recommend some counseling or something, because at that point it's considered more of a depression. So 2 weeks out, we're worried more about depression. Okay. So next week, or not next week, but the week after, when we start talking about complications, we need to observe, we need to learn what are some complications in the postpartum period. So if you had a laceration when our client did, we need to make sure that is intact, the sutures are intact, and we can teach her about hygiene. We have some solution. It's a topical anesthetic that she can spray to give her some relief. We need to be observant for any kind of hematoma development. And these are painful. Okay, these are painful. This is something, if your client complains that she's having pain down there, is probably what she would say, but in her vulva area, then we need to look and see if she's developing a hematoma. Now, you can apply ice, but you do need to call the provider. Okay, there's not much else you can do for that. It needs to be surgically looked at by the provider to determine if surgery needs to be performed. And then lastly is a picture of some internal hemorrhoids. So make sure you're assessing the rectum for any hemorrhoids. Usually during pregnancy, those hemorrhoids get worse. During the postpartum period, they hopefully begin to shrink a little bit. And then we can recommend like witch hazel for any external hemorrhoids. Okay, so that's just a further assessment of the postpartum period. And these are associated with more of the high-risk areas. Okay. Any questions about any of that? So remember, our priority in postpartum is the fundus. Okay, so when you walk into a client's room and she's postpartum 30 minutes, don't take time to do a neuro assessment. Okay, you do want to wash your hand, put gloves on, and make sure you're taking care of the right client. Do the 2 patient identifiers. Don't spend time looking at the monitor or looking at the blood pressure cuff, because you know if her blood pressure is down, it's late sign for bleeding. So you want to go directly to the fundus. Okay, check that it's contracting, and then check her bladder. Okay, bladder's not going to allow it to contract. Some of the other instructors use the mnemonic called bubbly. B-U-B-B, and it talks about assessing the breast, the uterus, the bowel, the bladder. But what I want you to understand is, yes, that's nice as a reminder, but your priority is more like an Uber, okay? The uterus first, okay? The B would be the bladder next. The E is a perineum for episiotomy or laceration. And then the R would be the rectum. Okay, so remember Uber instead. That way you've got your priorities. You know what as a postpartum nurse, that's what you're focusing on. Okay, so because you know that the #1 mortality is bleeding. And if you get your priority assessments down pat, then you'll save your client. Okay. So remember Uber. I think I might have put him in the postpartum. We do have a few more minutes. Anybody have a question? You can ask me questions about the exam as well, since everybody is taking the exam. It wasn't easy, I know.
When would we get the results? This afternoon or tomorrow?